afternoon at this point. We just flipped into the 12 o'clock lunch hour. It is August 11, 2022, and we're at the Deuk Spine Institute, Surgery Center of Viera, performing a Deuk laser disc repair on a patient with 20 plus years history of back pain. She's got degenerative disc disease and annular tears at L3-L4, L5-S1. She's already had a fusion done at L4-5. I didn't do the fusion. And we're going to get an x-ray right now, and you'll be able to see the hardware that we're talking about. So, Jordan, why don't we show the audience the screws that are called pedicle screws. There you go. You can actually see the threads on the screws. So what Jordan's pointing to right now is the screws at L4. Show them the screws at L5 again. And now show them the rod that connects them. There's the rod. There's actually 4 screws, 2 on the right, 2 on the left, and then a rod that connects the screw heads. That's a instrumentation, folks. And the fusion actually occurs in the posterior elements. So now we have adjacent segment disease as a result of her prior fusion. She's got a bad disc above the fusion, a bad disc below. So she's having more surgery. That's why we don't like fusions. We don't recommend them. They're unnecessary. They cause problems. And they don't fix the back or leg pain as well as the Deuk laser disc repair. All right, so we've got a needle at L5-S1, and we are going into that L5-S1 disc right now. We're going to fix this disc in just a few minutes. Shot? So we are at L5-S1. She okay? Shot? Yep. That went nicely. Now we're fixing the L5-S1 on the left because she's got left leg pain and neurogenic symptoms on the left coming from the L5-S1 disc. Now on the right side, she's actually got an L3-4 herniation. Now she's very thin, by the way, so I'm taking that into account as I'm planning my trajectory. All right, it could be a little bit higher. We've already numbed her up in that area. Shot. Again, it's a little hard to see the needle because of the screws and rods that are already there. Shot. We're right up against the facet joint at this point. Shot. Are you comfortable? The patient is awake just for the beginning. Shot.
She said yes.
Yeah. AP. Now the nice thing about endoscopic Deuk laser disc repair to fix the herniated disc is we don't really have any bleeding. We'll have a few drops here or there, of course, because it's a surgery. Let's take a look at a little more to your side, Jordan. All right, very good. Let's go back to the lateral view. You can see that we're aiming now above the fusion where the screws and rods are. So she had this fusion done by some other doctor. I don't know who did it. It wasn't me. Shot. But this doctor did a fusion and she's still having pain. And of course
the... Feel that, sweetheart? In your back or your leg? Your back?
Shot. I can feel the herniation. Yeah, poor thing. We're ready to test and sleep, okay? Are you comfy? So here's our blood loss, folks, just so you can see. 2 drops, not even a real drop, more of a fifth of a drop.
Can we switch lights, please? Thank you.
All right. That's my picture there. Jordan? Shot? That's it there?
Yes, sir.
All right. Folks, she has a fusion right here at L4-5, okay? With those screws and rods. We're not going to mess with her fusion because fusion is not where her pain's coming from. Her pain is, I believe, coming from above the fusion. And this is the L3-4 disc, which is damaged. And then again below the fusion, which is the L5-S1 disc. Are you awake?
You with us, sweetheart?
She's had back pain for 20 plus years. All right. we got to have her awake. Go ahead, Louise.
How you doing, sweetheart? You all right? Good. She's awake.
All right, we're going to put you to sleep in a minute, okay? Can you hear me? All right, so she's awake now. We put her to sleep a little bit earlier, but now she's awake. Are you comfy?
Yes
Huh?
or no? Are you comfortable? Yes.
She's comfy? All right. This is a pretty scarred up disc. See if I can even get anything in there. There we go. How bad is that on a scale of 1 to 10? How high does it go?
10.
10. Is that where you get pain typically?
Yes.
Okay, so you couldn't hear her. She moved a little bit. I heard her say, ow, ow. She said this is a 10 out of 10. That means that's the worst pain you can have. And she said it was the typical pain. We call it concordant. So there's a C. And that's because she's got a tear with inflammation right there at L5-S1. Are you better? I took the pressure off. You can see, by the way, you can see on that X-ray, go back to the X-ray, Henry. You can see the dye is leaked out. Jordan, you want to show how it's just leaked out of the tear in the back there, and it's just spilled everywhere outside the spine. So the nice thing about the dye is non-toxic. We would never use toxic. It's, of course, FDA approved, and we need it. It's got two parts, part that we can see on the X-ray and part that we can see endoscopically. Are you better? Yeah? She comfy? What'd she say?
She said she can feel it a little bit.
All right. A little bit? Are you okay, though?
She said yes.
Mm-hmm. All right. You see her tense up there? How bad is that on a scale of 1 to 10?
What's that?
I think she said 10. That's a 10. Yeah. Is that where you get your back pain?
Is that where you normally get your pain?
Is that where you typically get your pain?
What? Yes.
All right, so that's concordant. You can put her to sleep. So at this point, we've done everything we need to do with the patient awake, and we're going to put her to sleep and do her surgery, the rest of her surgery. It's going to start by making a cut right here. I'm going to give her some more local first. Luis, I'm going to take some local, okay? So local is just an injection of numbing medicine called lidocaine as well as marcaine and a little epinephrine. The reason you have epinephrine is to keep the bleeding minimized from cutting the skin. And then the lidocaine is a very fast-acting numbing medicine, and the marcaine is a more longer-acting for several hours numbing medicine. So we're giving her lidocaine and marcaine and epinephrine. It's pretty standard. It's what every surgeon does. Nothing unique about that. We're going to start with L5-S1. Now the incision is 7 millimeters. So that's what we're doing. That's the whole incision, folks, 1/4 inch. All right, let's take a look at that X-ray and shot. Want to leave the guide wire and take out the needle. Shot. Perfect. She's very skinny, by the way. She has no fat at all, and she's very thin. So the spine is very close, and we're not going to have to go very deep at all. Now we're going to bring the dilator down. I'll show you guys what we're doing. You see how the end of this dilator is tapered, Henry?
Yeah, we see it.
Yeah, that way it doesn't cut anything. It literally just spreads open tissues. Kind of like if you put a pencil in a bowl of Jell-O, and then you push it through the Jell-O, it'll go down to the bottom of the cup, and then you take it out, and there's no damage to the Jell-O. You might see where it was, a little line there, but that's it. So we're actually spreading things apart here, not cutting, not damaging. And the tissues we're spreading apart have fibers, like muscle fibers or fascia. And what the fibers do is when you push through them, they open. When you take it out, they close back. Is she comfortable enough to proceed? We are now at the back of the L5. Are you locked on orbit? Because I feel like it's moving a little bit on orbit. Shot. All right, here we go. Shot. Perfect. So now that I've got the dilator started, I'm going to take out the guide wire and I'm going to finish shot placing this. Now we've just gone through this tear that she has in the back of her disc called the annular tear. Radiologists don't talk about the annular tear very much because every herniation has an annular tear. Every degenerated disc starts with an annular tear and a herniation. Okay, and then over time, as the inflammation from the annular tear destroys the disc collapses and darkens, and it gets desiccated, dried out. It's all part of an inflammatory process going on in the disc. All right, so we're done with the tube. I'm happy with the tube position on the x-ray. Remember, x-rays are two-dimensional pictures. The patient's spine is three-dimensional, so the x-ray only gives you a little bit of information. It doesn't give you the whole picture. That's why you have to have a lot of experience doing these open surgeries like I did in order to know where you are in the body. If you have questions, feel free to ask them. Just type them up in the dialog box and I'll be happy to answer them during the surgery. But Henry, you can see the whole surgery is going to be done with this tube right here. It's a 7mm tube. Now this is the endoscope, folks. We do the whole surgery using the endoscope down the tube. We have some irrigation and light.
Angle on the ceiling, please. We got it.
All right.
I need the picture.
And let's get started. Now, whenever you have a disc that's badly collapsed like this one, and it's degenerated, there's been inflammation going on for a long time. And that inflammation, it brings with it blood supply. And that's what we're seeing here is a little bit of bleeding from the inflammation. Not a big deal. There we go. All right. Now we're going to bring the laser in and get started debriding the annular tear. These surgeries are really annular debridements. Visibility is not going to be so good right now for you guys because, like I said, the haziness comes from the bleeding, from the end plates and from the inflammatory tissue. Not a lot of bleeding going on, but there is a little bit. And I've done a few of these, so I'm kind of used to dealing with a little bleeding. It doesn't bother me so much because I can still see what I'm doing and I know where the things are that I've got to fix. It's kind of like going into your garage at night. You know where the garage door is, even though you can't see it. You know where it is in general. I think this is more just, you can control her blood pressure, but I don't think this isn't muscle bleeding or anything like that. This is more coming from this degenerated disc, which you can see is, see the end plates right there? That's where the bleeding always comes from, is the bone. Little veins that cross and go in there called emissary veins. Yeah, very nice control of the anesthesia, by the way. Thank you. Standby laser. I'm going to grab some of that old scarred up disc out. Oh no, we don't turn the scope off. Who turned the scope off? That's only cervical.
Thank you.
No. Well, you do at some point if I take it out, but. Yeah, hold on. Yeah, it's not like the cervical where I got to take the scope out to grab it. I use the grabber in the scope here. It's all right. You're learning. All right, you can see the annular tear right here that I'm debriding. It's blue. The herniation stuck in the tear is blue. The tear itself is white. The annulus fibrosus is made up of collagen and elastin. The nucleus pulposus, on the other hand, is not made up of collagen. It's made up of what are called proteoglycans, which are long protein chains that have a sugar attached to them. So it's really a combination of a protein and a sugar. proteoglycan. They bind to water. They hold water. We call it hydrophilic because they bind water. There's a piece of the herniation right there. I shoved it back into the disc when I went in with that dilator. So now I just got to fish it out. So any questions from our audience so far?
No current questions.
And do we run the video showing why people get back pain from a herniated disc yet?
Not yet.
Let's do that. Let's show the audience why do patients with a annular tear and a herniation or a degenerative disc, why do they get back pain? It's actually right here, this tear up here. That's what we're cleaning out. Give me a countdown.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
We were just having a conversation while you guys were watching that video about how in the beginning when I started doing these procedures, I was doing endoscopic surgery years ago for herniated discs, and what I was trying to take out was the herniation, the piece of jelly that went through the tear and was on the other side of the disc outside in the epidural space or the foramen. And I had patients that would come to me with degenerated discs, degenerative disc disease, like this patient, where they really didn't have a big herniation. The herniation was very small, but they had horrible pain in their back, and they wanted the laser surgery done. And I thought, you know, I don't know. I was taught to do it for herniations, but not really degenerative discs, but we could try it. Because they were adamant. They didn't want a fusion. So they were willing to do it. I was willing to try it. Because I had done some discs that were partially degenerated with good results. Like if you have a degenerative disc in a patient with a herniation, and you go after the herniation and the pain goes away, you realize it's not the degenerative disc part that's causing the pain. You know, it's still the herniation part, I guess, that's causing the pain. So I started doing all these surgeries on degenerative disc, herniated disc, bulging disc, and the result was always the same. The pain would go away. And I realized, what do they all have in common? They all have an annular tear. They all have an inflammatory mass, like this right here. And if I zap that away, and that's what was that was the common denominator, was that I was removing the inflammatory tissue, the place where the inflammation was, and getting rid of it. And that's when I realized it was the annular tear that was the source of pain. That's why I published it. And that's why we keep doing it, because it works. All right, we're just about done here. I got to take another peek. And again, I apologize. There's some fat right there. That's what fat looks like. You can see some oil right there off to the side coming out of the fat cells. But each of those is a fat cell. Each of those little crystal-like things is a cell. And there's some fat. Okay, pretty cool. We just did some liposuction there, and we don't charge for it. It's complimentary. Yeah. Yeah, it's normal. That's 100% normal right there. It's just getting in my way, so I have to zap it a little bit. It's not going to hurt the patient to remove some fat. We all know that. All right. I would say 30 seconds. We're not here to take fat out, by the way, but sometimes the fat blocks your view of what you need to see, so you got to get rid of a little bit. And that's what I was just doing right there. Now that's called epidural fat. It's located in the epidural space, just right around the nerve root. The nerve is actually just above that thing. So I'm staying away from the nerve root. I'm just cleaning up the back of this disc where the inflammation, all this is scar tissue from inflammation. This is where all the pain comes from. This posterior annular tear. Again, that was discovered by me at Deuk Spine Institute about 16 years ago, published 10 years ago. We've been doing this surgery 16 years at Deuk Spine. All right. Looking good. Just to give you orientation, the left is the end plate of L5 and the right is the end plate of S1. We're at the back of the disc at L5-S1 on the patient's left side. I've gotten rid of the herniation using the laser. And I've gotten rid of I debrided the annular tear, gotten rid of all the inflammatory tissue and nerves, painful nerve fibers that come with inflammation. A lot of people don't know that you grow nerves even throughout your entire life. And those nerves come in with inflammation. So wherever you have inflammation, you get nerves. Don't ask me why. That's just the way God made us. Done. Where that cavity is right there in the middle, that's where the herniation was. So it's gone. We're going to do one more disc and we'll be done with this patient. Get her off to the recovery area.
Scope off, please. Thank you.
All right, we're going to put some antiseptic, betadine. Good job, guys. Irrigation. All right, any questions from our audience?
No current questions yet.
Our audience knows everything. We got smart people watching.
Yeah.
So let's show the audience what the Deuk laser disc repair actually does. What are we doing in there? Let's do a little more irrigation.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. You've just watched our animation showing how the Deuk laser disc repair works in the lower back. All right, Oscar, are you ready to put some pressure here? I'm going to go around to the other side. So we're putting a little pressure on the incision, and more so not the incision, because the incision is not going to bleed much. It's the muscles we want to make sure they're not bleeding. So we put, if you think about where the incision is, we actually go towards the midline, So look here, you're fine. See the midline?
Yep.
Here, there's the incision. We put pressure right between. That's where the muscle is. So you want to put pressure on the muscle belly. And you want to put about 4 minutes of pressure just to make sure that any vein bleeding will stop. So I've made another incision. And let's get a shot. Nice. We're going to be working above the fusion now at the L3-4 disc. Remember, her fusion is at L4-5. So we're going to go above her fusion now and fix the next disc. Oscar, how are we doing over there? Good? All right. Shot. Here we go. You see the dilator is just passing next to the screws. Almost looks like a screw itself, doesn't it? What's hitting me? Fiber. All right. She okay? Ready for a little stim? Shot. You see a little antrolisthesis there. Shot. Now the beauty of this system is that the guide wire guides the dilator. So the dilator has to follow the guide wire. It has no choice because the guide wire is metal, yeah. And that's really what we want. We want the dilator to follow the guide wire right into the safe parts of the disc. Shot. Just about done there, shot. Need to go a little further. That's perfect. Now, if this patient didn't have the Deuk laser disc repair, she didn't know about it, she wasn't here, she'd be getting another fusion. And that's the problem. A lot of these fusion surgeons, they just want to keep fusing and fusing. They're happy to have the patients come back and get more fusion, because that's how they make their money. We want to do this one time and not have the patients come back. That's why at Deuk Spine we fix patients right the first time. Now some people have to come back because they re-herniate, or maybe they have other problems like facet pain, but the treatments we do generally last. And we were talking last surgery about the lumbar Deuk laser disc repair. This particular surgery, we have long-term outcome data where we studied how the patients were doing 6 years after the surgery, and they still had 92% of their back pain was gone. Their preoperative back pain. That's pretty darn good. As well as 92% of their leg pain. Okay, going into the next disc is L3-4 on the right side. Now, why do we choose the right side for this disc? Because she had right leg pain. And when we looked at the two discs, L3-4 was the one that was causing the right leg pain, based on the MRI findings, based on the physical and based on the EMG. All right. Once again, she's had 20 years of chronic back pain. She's already had a fusion. We didn't do her original fusion. I would have tried to talk her out of it. There we go. Good job. We need 10 minutes, doctor. We'll be done in 10 minutes or less. Probably 10 minutes. Where's my pedal, guys? Yeah. Thank you, that's good. Thank you, no, that's perfect. That IV pole is right in my way of my sight. Better. Thank you. Yep. Thank you. Thank you. That's perfect, Jordan. Thank you.
Jordan's very nimble.
He is.
Notice that?
Jordan moves with his mind. He's a mind mover, a shapeshifter. People that move with their mind move faster. You plan everything out in your head, you know what needs to be done, and you get there a little earlier than the next person.
I might be one of those too.
Huh? You probably are. I know I am. I always see what I'm going to do before I do it. I visualize it. Visualizations. All right, well, this poor lady, I'm going to tell you a little bit about her. She's just, how old is she?
She is
77. So for those of you who think, oh, I'm too old to get my back fixed, you're not. We've operated on 90-year-olds. The reality is do you want to live the rest of your life in pain? Folks, this is really good here. Check this out now, Henry. Look at this. There's the annular tear. There's the right side of the annulus, the top fibers, and there's the left side. See the white stuff?
Yeah.
Now in between is a huge tear, and the blue stuff is the herniated nucleus. That's what we're going to debride. And when we do debride it, that pain will be gone. It will actually grow back, the annulus. It'll repair itself. It just can't repair itself because of the blue stuff that's stuck in there. Let's get a grabber. Uh-huh. Everything okay? All right. Another piece of herniation. All right, folks, you got to ask questions so I can have something to talk about. Otherwise, I'll start talking about whatever comes to my mind. Yes. Oh, good. Liz, fire away. Yeah, the space will go back. So the question was, if someone has a herniated disc, say in their neck, and it's pushing on the spinal cord, pushing and crushing the spinal cord, squeezing it down, will the spinal cord go back and like fill back out to what it normally is supposed to look like? The answer is usually yes, it will. And it just depends on how long that compression is. And ultimately what it really depends on is how much damage there is from the compression. Because the longer it is compressed, the more scarring you get, and scar tissue is non-compliant. It doesn't go back. It just stays there. So they've done studies and looked at the spinal cord after decompression, and some people it goes back to normal and some people it doesn't. This is like sliding out, so you gotta, I don't know.
I'm holding it, sir.
Huh?
I'm holding it right
Yeah, you are, where you are. But it just, when I let go, it seems to want to back out. It's fine. It's nothing you're doing. I'm just seeing if you can help me prevent it from backing out. Like, I don't know if it's just the... All right. Any questions from our audience, Henry?
We just got one from Facebook,
Great.
Sue Griffin.
Hi, Sue. How are you today?
And they asked, hello, you now have MRI images from 2019 with herniation and one from this year showing the improvement after the DLDR. You're more than welcome to use the images if they are helpful.
Oh, thank you, Sue. I appreciate that. But, you know, I'll be honest with you, Sue. Sue is one of our regular viewers and a contributor and an expert in spine issues. She's educated herself. But she brings up a great point. She wants to know if I'm interested in using some MRI pictures. And I'll be honest with you, I think it just sends the wrong message, because I don't want people focused on their MRI. I want people focused on their symptoms. We don't do this surgery for their MRI. We do it for their symptoms. And my goal is to cure neck pain, or sorry, in this case, back pain, to cure back pain, cure leg pain, cure weakness, numbness, and tingling from a pinched nerve. That's what our goal is with this surgery. And if I achieve that without making the MRI look any better, then I still achieve the goal. So I just think there's too much focus in the public on MRIs, and wrongfully so. And people are just so obsessed with their MRIs and what they show. And we need to be paying more attention to what symptoms they cause rather than what they show. So I would rather avoid, and that's why I've avoided it, by the way. I have my own MRI scanner. I could get MRIs on every patient that I operate on, but I don't. And the reason I don't is there's no reason to get them. They don't prove anything, I don't think. Nothing that's important. And I don't want people falling into that trap of believing because the MRI looks good, they're good. Because that's what a lot of surgeons do. Patients come back after spine surgery, they say, "Doctor, I'm still in pain, I have numbness still, I have whatever." And the doctor says, "Well, your x-rays look good, your MRI looks good, you're fine, there's nothing wrong with you." So I don't want to perpetuate that myth by focusing on what MRIs look like. I want to re-educate the world and get them to understand what matters is the patient's symptoms, and the physical exam is more important. The MRI is just to confirm what the doctor already suspects based on a clinical finding. The diagnosis about the source of back and neck pain, leg and arm pain, sciatica, is really a clinical diagnosis, and I understand that more so now than ever before. I was heavily reliant on MRIs when I was a resident, but that's because I was taught by my attendings the wrong way. And I don't want to perpetuate that misinformation. I want to teach people the right way to think about chronic back and neck pain, which is should be patient symptom based, patient reported symptoms rather than MRIs and x-rays. All right, there's a piece of herniation there, but thank you for the generous offer. Trying to wiggle out the herniation right there. You guys see it? It's like a mass right here. It's stuck down, by the way, scarred from all that inflammation over the years, and I'm trying to grab it and pull it out. I could laser it, but the laser will take a long time to break it up, so I'm trying to just get a good grab on it and pull it. It's coming out in pieces. At least it's coming out. That's what matters. See the little bit of bleeding there? That's all inflammatory tissue. So that's where the inflammation is. It's causing all of her symptoms in her back with her back pain. We're going to get rid of that source of inflammation. All right, laser. We need 5 minutes, doctor. 5 minutes, we'll be done. Maybe even less than 5. So Sue, you may be interested to know we're getting ready to take on the big insurance companies on the Deuk laser disc repair. We've had really good results in terms of outcomes, and we have put together, as you probably know, what's called an appeals package, and we've got the right people in place, and I think we're gonna end up. We won't have resolution this year, of course, because I fully expect to go to litigation with the big companies. So we're looking at probably 3 to 5 years for resolution. But we have hundreds and hundreds of patients that want this surgery or have had it, and they want their insurance to pay for it, and they should. So we're going to help them achieve that. And that's going to open the door to more people in the future to be able to get this Deuk laser disc repair. She's moving a little bit, but I'm almost done. So, all right.
Sue Griffin replied back from Facebook, and she said, brilliant news with the insurance companies, fingers crossed.
Yeah, thank you. Oh, by the way, Sue, you might be interested to know, we haven't talked about Arias and his racing in a while, but I had him on Van Amersfoort. Unfortunately, Van Amersfoort in F4, Italian F4 this year, they just cannot get the car engineered properly. And I'm using the word car loosely because I think there's engine issues in terms of power output, and there's chassis issues with engineering the chassis. Point is, they haven't been able to make the car fast for any of the drivers. It's nearly the end of the season. We've stopped racing Italian F4, and we're focusing now on this next step, which is going to be FIA F3. So the biggest issue, though, is getting on a team. So if you know anybody at High Tech or not Carlin, because Carlin is unfortunately slow as well in FIA F3. We don't want to go from a slow F4 to a slow F3. Let me know. But the intent is for Arias to race FIA F3 next year. You can imagine the biggest problem, as always, is the competition for seats is massive. They just have too many people willing to pay obscene amounts of money to race. So we're competing against all these other drivers. Now you may know this, I think I might have mentioned it, but Arias competed for a seat on VAR, Van Amersfoort Racing, for F4. He went to Misano, went up against the fastest drivers in the world in F4, and he was fastest in the dry on the second day, and second fastest in the wet. And of course they awarded him a seat, the only seat they had. They had 160 drivers trying to get that seat. So he got that seat, but the team just basically really just dropped the ball with the new car. Last year's car was really fast because they had it for many years to engineer it properly. But this year's car, the new car with the halo and the new engine, they haven't figured it out. And we've been running a second and a half behind the lead pace, even though our drivers are probably faster than the fastest drivers on the Prema team, Stenshorn and Arias. But we just can't prove it. So it's time to stop banging our head against the wall. We quit Italian F4. We're going to run FIA F3 next year. We just need to find the right team. Done. Good job, everybody. Looks like the herniation's gone. We're done with this. Did you show the video comparing DLDR to Fusion?
Not yet. We showed the back pain and the DLDR.
Yeah, let's do the comparison, like what she would have been doing had we done another Fusion. All right?
All right.
Before you do that, though, let's just take a quick look, and I'm going to show you the incision that we made. Can you see this over here?
Yeah, we can see it.
There's the whole surgery is done through two incisions, one on the left, one on the right, like that. All right. Give me a countdown.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Crosslinks are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. R. Deuk Majan with the Deuk Spine Institute, and I'm here with one of my patients who just had the Deuk laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Deuk Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. The only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Deuk Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody near us or anywhere near us that had any other option besides either getting a discectomy or a laminectomy or a fusion. There was just nobody was doing anything else. And I knew I didn't want to do that again because I'd already had that done. So it didn't work. And
Didn't work.
I had a really amazing physical therapist that connected me with you, and the rest is history.
Yeah, your physical therapist found us and was intrigued with the surgeries we're doing here
Yeah.
and sent you here.
Mm-hmm.
So what are you going to tell your physical therapist? I call him Dr. Salinas. What are you going to tell him when you...
Oh man, I've already told him. I texted him the minute I got back to our Airbnb. I said, I feel amazing, and I can't wait to tell all the rest of the patients in our Facebook group, like, this works. So
It does. The Deuk laser disc repair really does work. Well, is there anything else you want to say to your fans out there or friends?
my fans and my friends, thank you for praying. Thank you for believing me. I think that's one of the biggest things. There's a stigma around back pain because you can't see it, that people are just faking it, or maybe they're babies. Like, why can't you just deal with the pain? And it overwhelms you. And so to come someplace that believes me and then fixes the problem, and now I'm sitting here and I can be like a fully active mom. So I'm just beyond thankful. Thank you.
Yeah, chronic pain robs people of their dignity and their happiness and joy in life, and also their loved ones, the people that care about them.
Yeah.
Because they suffer with you.
Yeah.
Yeah.
A lot.
Well, congratulations and praise God.
Yes.
You found us.
Thank you very much.
And I think you're going to do fantastic.
I'm looking forward to being strong again.
Awesome. All
Yes.
right. It's Dr. Deuk at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well, thank
And I
you.
came in with a lot of pain, a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
yeah, and I'm A1 now.
Awesome. So you had your surgery, you've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too, when you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
Not too soon with any of that lifting engines.
all right,
and
all
contorting your
right,
body.
yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well, congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You're
God
welcome,
bless.
sir. God bless you. I'm Dr. Deuk here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration, where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means, it's because I hurt so bad. I'd never experienced pain like that. And like I said, there's no
because
rest.
you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since
Yep.
we did your surgery. You went home an hour after the surgery, back to your hotel with your
Yep.
lovely family who I met.
Yep.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I'm just going to rest and watch TV, but then we're going to get on a plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith.
Yes.
Took the
I have
leap,
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome. All right, I'm here with one of my patients who traveled from Australia to Florida to the Deuk Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone from
Awesome.
the disc here.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Deuk laser disc repair.
I had the Deuk laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Deuk laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Deuk. I found Dr. Deuk, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L5-S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain about with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma. There's no scar tissue. There's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, you said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and their loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing.
2, 1.
Okay, I heard that there was some grumbling in the peanut gallery about the testimonials, so here I am. I was just having some animal crackers. I don't recommend them if you're diabetic, but they are good. Checking on our post-ops and checking in the new pre-op. So thanks for being patient. Dr. Deuk Majan here. We've just completed a Deuk laser disc repair on a patient who's had fusion done before on her back. And with fusion, what you're trying to do is get a bone to grow onto another bone across a painful, diseased joint. And so by fusing two bones across a painful joint, you stop the movement, it gets rid of the pain. The problem with fusion, though, is most surgeons don't do it properly, so it ends up causing problems above and below the fusion, like this patient had. She had a degenerated disc at the bottom, L5-S1, a fusion at L4, L5, and then a bad disc above at L3-4. And it just so happened to be that the L5-S1 disc herniation was on one side, and then the L3-4 was on the other side. So I went in with my needle like this from the side, and I went past the facet and into the tear and herniation, and I pushed it back into the disc. Then we brought the tube down, and I removed the herniation, and I cleaned up the annular tear using the laser. We just did that at L3-4 and L5-S1. So surgery went well. I think our patient's going to do very well. If you noticed in the beginning, we did a discogram, and that's where I actually will test those two discs that I'm operating on to see if they're causing her pain. The nice thing about the discogram is I wouldn't probably normally do it on its own, but because it's really part of the surgery, I get to do the discogram and I get to see her pain response. So the discogram confirmed that she had 10 out of 10 pain at the top disc, L3-4, above the fusion, and she had 10 out of 10 pain at the disc below the fusion. So I felt really good that if I'm going to fix these discs with the laser surgery, she's going to be out of pain. All right, let's take our first question.
All right, this first one comes from DM Maker on Facebook.
Ah, DM Maker.
Yeah. And
He's one of our Facebook mentors. I'm not sure the exact title, but I think it's a moderator. Thank you for writing in, DM Maker.
And this was talking back to deposition that you're going through. Can the claims be retroactive?
DM Maker. Can the claims be retroactive? So I don't remember what your insurance is, but remember Medicare is not going to be part of this because Medicare has completely different laws, and we're focusing on commercial ERISA claims. ERISA is the federal law that controls commercial insurance plans and how they pay for the benefits that are defined within those plans. And it has nothing to do with Medicare law. We're not taking on Medicare right now. Medicare will not pay for the Deuk laser disc repair that you just watched at this time. We don't want people thinking it will. But ERISA is the employee retirement insurance. I can't remember what the acronym is, but it's basically a set of laws that govern how insurance companies like Blue Cross, Cigna, United Healthcare, how they pay for people who have insurance through their employer under the ERISA plan. And that's what we're going after right now. Retroactive, we can go back to 2019. I forgot the month. It's somewhere in the middle of 2019. And that's what we're doing. Right now, we're collecting all the claims that we've submitted and cleaning them up, making sure that we have all the documentation in place, and we have an appeals packet that we're using. So we're basically going through a very extensive process of putting together all the documentation necessary to bring these claims to some type of a final determination from the insurance company. We expect they'll deny the payments for the most part, though I got to be honest, we are getting some payments coming in for the Deuk laser disc repair, some from United Healthcare, some from Blue Cross. I don't think we've seen a Cigna in a while. We haven't seen a Humana in a while, but we have a lot of other insurances as well that do pay for the Deuk laser disc repair. It's just the ones that aren't paying, that should be paying, are the ones we're going after. I don't know if that answers your question.
So the next come from Sue Griffin on Facebook. These are not questions, but regarding with Argus and F3.
Oh.
She's like, ooh, F3. I'm Chief Screw It at Anglesey in September. Brands Hatch Paddock Pass is a good hunting ground. Get Arias to follow Billy Munger and Jamie Caroline. I will keep my ears open.
All right, well, thanks, Sue. I appreciate the comments. You know, the hardest thing, to be honest, is just to get on a team. You'd never think that it would be so difficult to spend a lot of money. You know, FIF3 is expensive. I'm just shocked at how many people are able to do it at the cost. So anyway, keep your fingers crossed. Hopefully we'll get on a good team. Thank you for your thoughts.
This next question comes from Ben Price on YouTube. And they asked, if the annulus takes up to 18 months to heal, what prevents further herniation through the existing tear? That's a really good question.
Yeah, Ben, thanks for asking. If the annulus takes up to 18 months to heal, it actually takes up about a year to heal, 12. What's to keep more jelly from the center from herniating out? Great question. If the answer, simply put, is what's called restrictions. We give patients restrictions on their activities after surgery, specifically the kind of activities that would push more herniated disc out is anything where you load your spine, where you put force down, and that comes from lifting things and bending. So if you look here in the little hole, in the little window there, you can see the herniation coming out.
See that?
Let's see.
Yeah.
Right there. Right there. So if you put pressure, you can see the herniation, the jelly squeezing out through the tear. And then when you stop bending and lifting, it goes back in. When you bend and lift, it comes out. So you want to avoid lifting and bending at the waist. That will prevent pushing the jelly back out through the defect that's there. The jelly isn't watery. It doesn't just run out. It's actually pretty thick and clumpy, and it stays where it's supposed to, unless there's pressure from bones squeezing down, pushing it out the hole.
This next one is from Khalid Madni on YouTube.
Hello, Khalid.
I don't know if this is a question, but he goes, this procedure is correct. Open surgery for fusion, not for discectomy. Endoscopic surgery used for disc prolapse and release for spinal stenosis. If bad, degenerative a degenerated disc and stenosis, TLIF is the best option.
Khalid, very good. I agree with you. I'm not sure if you're a doctor, but that sounds about right. I agree with you. So Khalid made a very good observation that if what we're treating is a herniated disc, like we did with this lady, or degenerated disc, do the endoscopic first and reserve the open surgeries just for fusions that are only necessary if the patient basically fails to improve with the endoscopic procedures. I agree. Unfortunately, I'm one neurosurgeon in the United States out of 6,000 spine surgeons, 3,000 orthopedic, 3,000 neuro, 6,000 surgeons that operate on the spine, and the other 5,999 don't know how to do endoscopic surgery. I mean, there's a few that do, maybe 5. And unfortunately, those large number of spine surgeons, they want to do a lot of fusions. They want to do a lot of metal because that's what they're trained to do in their residency. And the problem is, it's very damaging to the patient's body to do the surgery, plus a loss of movement and adjacent segment disease and complications. So I agree with you, Khalid. The open surgery should be reserved for people who fail endoscopic.
Awesome. And then last but not least, Sue Griffin from Facebook. And I agree with her. I wish the UK would embrace DLDR. So good to see more patients doing really well after the surgery on your videos.
Hey Sue, thanks for making that comment. The thing about it is that the UK has medical schools and residency training programs just like the United States. If this procedure was taught to residents in their training programs, the residents would do it when they get out. Now, they would still have the financial disincentive, which means if they're trained in residency, they'll learn to do fusion, they'll learn to do Deuk laser disc repair, they'll go out in the real world, and if they make a lot more money doing fusions, they're going to keep doing fusions. The reason I say this is we've seen this happen already with artificial discs. See, fusions have been around longer than artificial discs. Now, if a surgeon that does a fusion in the lower back, you're going to bill for putting the cage in, you get paid $500. You're going to bill for the inner body arthrodesis, fusing the inner body space, that's another $1,000, $1,200. You're going to bill and get paid for putting the screws in, that's $800. You're going to get bill and get paid for putting in the fusion in the back. There's another $1,000. And then of course there's other codes as well, like the laminectomy code. Point is, when all is said and done, fusion pays $10,000 to the surgeon. An artificial disc will pay $5,000 to the surgeon. So the surgeon is going to get half as much money for doing an artificial disc, which is, I think, theoretically is supposed to be better than a fusion, but it pays less. In the real world, artificial discs don't work as well, in my opinion, as a good fusion. But that's besides the point. The point is, there's a differential payment based on what procedure you're doing with a higher financial reward for fusion, okay? And endoscopic surgery pays the least. If you get $10,000 for a fusion, you get $5,000 for an artificial disc. The surgeon may get $1,000 to $1,500 for an endoscopic procedure. So and guess who decides what procedure to do? I mean, the patient does, but it's the surgeon who steers them. So the surgeon really decides what procedure to do. And the surgeons are unfortunately going to continue to be motivated to do what pays the bills, especially as the cost of running a medical practice continues to rise over the years, as it has for the last 30 years, 40 years. And the reimbursements are getting fewer. The insurance companies are making it harder to do surgery. So what I'm getting at is that the whole system is messed up, and it favors utilization of higher revenue procedures that are more invasive, and that needs to change. That's a cultural change that needs to occur, and it will happen someday, but it won't just happen on its own. It happened with me because for me, I want to set myself apart from my colleagues as providing the very best treatment in the world. Even if every spine surgeon in America did endoscopic surgery, I would still find a way to be better than them. Okay, because I'm a competitor. I like to compete. You can see it in my son, my daughter, my wife. We all never want to be anything less than the best at what we do. So even if everyone did endoscopic surgery, I'd find a way to separate myself and do it better. But that said, everyone's not doing endoscopic surgery. And so it's really easy for me to stand out as doing things better because all my colleagues are just still basically in the dark ages when it comes to the spine.
That is it.
I hope you enjoyed the surgery. We're going to have another one lined up for you in a few minutes. This next patient, she has 2 herniated discs in her back. They're bulging disc at L3-4, L4-5 on the left side. She also has facet joint pain. She wants a Deuk plasma rhizotomy. So maybe you'll see that today, but I'm not so sure. You'll see the laser surgery, that's for sure. And then Dr. Patel will also be doing a bilateral sacroiliac joint injection. Then what am I talking about? Well, basically, this patient has 2 painful discs, L3-4, L4-5. I'm going to repair those endoscopically. She also has facet joint pain here and here, and I'm going to do a rhizotomy on those, but a new type of rhizotomy called plasma rhizotomy that I discovered and developed. And then she's going to have her sacroiliac joints injected because she has SI joint pain and inflammation. So she's got a lot going on, but it highlights the fact that many patients have more than one cause of pain. She's got L3-4, L4-5 disc. She's got the left L3-4, L4-5 facet joint. She actually has right L3-4 and L4-5 facet joint, and then she's got right and left SI joint. So she's got 8 sources of back pain. We have to address each one of them.